So just to set the scene, all this work started when I was walking past a cubicle in my own emergency department one morning when a patient beckoned me in to her cubicle as she was trying to say something. But her voice was very soft and very weak. I could see that she was visibly tremoring. As I leaned across the bed towards her ear, she whispered into it, "I have Parkinson's and I need my tablets." I whispered into her ear, "So do I, and I'm going to help you." She then gave my hand the biggest squeeze I've ever experienced and had to whisper in her ear again to let go. It transpired that she hadn't received any of her Parkinson's medications that morning as they hadn't been prescribed. After I'd given them to her, I realised that encounter in an overcrowded ED with no flow had changed my whole perspective on this issue. Around the same time, myself and Claire Addison, who was diagnosed the same year as myself and is on the panel this morning, we set up an NHS Professionals with Parkinson's group. And out of that came a campaign to help patients like the one I've just mentioned. We know what it feels like when a dose is delayed or it's not taken at all. How it can ruin a family day out and take time to recover from. And that is in two reasonably fit young people. We can't begin to understand what it feels like for people with Parkinson's in hospital. So the first thing we decided to do was inject a degree of urgency by changing the words "get it on time" to "time critical medication," as we hoped NHS staff would identify with that more. We then put into motion a three-pronged plan with support from Parkinson's UK. The first stage was to get CEOs from acute hospitals in England, health boards and regions in Scotland, Wales and Northern Ireland, as well as support from chief nurses in all 4 nations and the ambulance service. Currently, 107 NHS executives have pledged their support to this. The second stage was then to write the 10 recommendations document for hospitals to help in the delivery of time-critical medication. This was followed, again with the help of Parkinson UK, by embarking on a benchmarking process. To date, 30% of these hospitals are taking action and driving positive change for the patient, and we'll hear about one such case study this morning. The final stage was to get engagement at the national level. So we were absolutely delighted when NHS England announced their 3-year Medicine Safety Improvement Programme, MedSIP, which will include time-critical medication. And the Royal College of Emergency Medicine has started a 3-year QUIP, with the first year just having been completed. The interim report will be published in April this year. So thank you for coming. I do hope that you get a lot out of this morning and you're able to bring back what you've learnt to your own trust and continue to drive change. Next slide. Thanks, Emily. I'm now going to let the panel introduce themselves to you, starting with Claire.
Yes, good morning, everybody. And can I just echo Johnny's thanks to you all for joining us. My name's Claire Addison. I'm a retired neuroscience nurse. I retired at Christmas after 42 years in the NHS. And as Johnny said, co-founder of the NHS Professionals with Parkinson's Group. I'm also a patient and public voice for NHS England Neurology Clinical Referencing Group. And I'm a campaigner for excellence in care for people with Parkinson's. Now I'd like to hand over to Nick.
Thank you, Claire. My name's Nick Bryden. I'm a Parkinson's specialist nurse in Ayrshire. I've been doing that job for 15 years. I've been looking at time critical meds for 14 years of that. And the reason I started was that Parkinson's UK had always quoted the figure of 50% of medications not given on time in hospital. And I, in my wisdom, thought I'd proved that wrong. I actually proved that we were worse than that when we started, but our project has led to a vast improvement. But there's lots of good projects going on out there, and I'll ask Fionnuala to introduce herself.
Hi, I'm Fiona Johnston. I'm a care of the elderly consultant at Sunderland Hospital with a special interest in Parkinson's disease, and I'm delighted to be here. And I look forward to sharing some of the work we've been doing at Sunderland and South Tyneside around this area.
Hi.
So sorry, I'll hand you over to Emma.
That's fine. Hi, I'm Emma Kirk. I'm a pharmacist. I'm a medication safety officer on the Wirral, and I'm also the medication safety officer network lead. That role is hosted by Specialist Pharmacy Service, and we have been commissioned by the MedSit programme to carry out the time critical medicine programme on behalf of them. So thanks for having me here today.
Great. So that's the panel. On to the next slide. Thanks, Emily. So that we've said who we are, and what we would like you to do now, just for a few minutes, is basically post in the chat. Let us know who you are, what your role is, and where you work, just so we get an idea of who's here. And also, what do you want to get out of today's webinar? And what I will do is I will feedback. So just in the chat, you can just say hello, who you are, what your role is, and where you work. And then secondly, what do you want to get out of today's webinar? So just as people do that, I mean, I'm looking particularly forward to the presentation, also the breakout rooms this afternoon, so we can start a good discussion and then get all our heads together and try to come up with some solutions that potentially we can bring back to our different hospitals. So we're either very slow typers or there hasn't been much uptake for the chat. I'll give you another minute, and then I will move on to the next part, which Claire will introduce.
I think people are just thinking about what they type, Johnny. It took me a little while, so don't worry. There's lots coming in on the chat now.
Oh, is it? Okay, that's fine.
Brilliant. I think probably we move on to the next bit, do we, Johnny?
Yeah, well, let's move on.
So in our mission to always put the patient at the centre of everything we do, we would like now to show you a short film. You'll be meeting Karen, who's going to share her experiences of being a patient in hospital.
If I was told that I had to go back into hospital for any reason, I would be really quite cautious about getting in, and God, I don't want to go through all that again. I've done it once and I don't know how my body will cope. It will be different from how I was treated then. I was 49 when I was diagnosed. It was a very big shock to myself, my husband and the rest of the family, because we've never had anybody in the family diagnosed with anything like that at all. It was something very new for us to navigate our way through. It affects your body in so many different ways. My off periods during the day and my on periods, you can definitely pick up on the different ones. Taking note of when my medication's kicking in, starting or wearing off is very important as well now. You know, having to make sure I take them, stick to my regime. I was admitted into hospital in September and of October last year, and nurses were like, "You've got Parkinson's, yeah. Have you got your medication?" I said, "Yes." "Do you know when to take it?" "Yes," and that was fine. Then I was admitted into hospital in January. The consultant came round and said that they were going to do an operation on my back and that it would be done through the night, so that when I get back to the ward in the morning, I would be there in time to take my medication for that full next 24 hours. It didn't work out the way that the consultant had said it would be. I went to open my little box to take my tablets that I take at 8 o'clock, and this nurse came and snapped the whole box out of my hand and said, "You're not allowed to take that. That's up to us to dispense it." And I says, "Well, I took all my medication on my own. Yesterday there was no problem." "Well, there's a problem with it now. You can't do that. We'll give you it." I'm a 53-year-old woman. I can perfectly take my own medication at home. Why some nurse has to feel the need to rip it out of my hand? But I was getting myself wound up because I needed my drugs and I knew that they were running over late. Then 12 o'clock came in and it was nearer 1 in the afternoon before I got it. And I said to them, "These drugs are critical for me. I should be taking these medications when my consultant decides, or my nurse. That's not me. It's decided on these times." But again, it just fell on deaf ears completely. I pressed the buzzer at 8 o'clock, said, I'm due my medication. I need this. And eventually at 20 past 10, the nurse walks into the room that I was sharing with another 3 ladies with the medication trolley. And I said, "I need my medication for Parkinson's." And she says, "You're not the only patient in this ward with Parkinson's." It must have been about 10 o'clock at night. I thought, I'm going to do something on Twitter. I put out a statement saying I'm in hospital, I've been left my medication's been off time the whole day. And people were replying back saying, that they had been in various other hospitals throughout the country, saying that this had happened to them, that this shouldn't be happening. From behind that, I then also got a personal tweet that I could go into Care Opinion and left a complaint on that about the way I was treated from the staff, the lack of empathy, the lack of consideration for people with Parkinson's with a time-critical medication. For that one time, even if it was on Twitter, I was being heard. They were reading my story and the empathy coming back was 100% better than what I was getting as a patient inside the hospital. The consequences of me not taking medication on time for that whole day carried on for days after, before my body went back to being the normal that it had been previous to that. I didn't really get an acknowledgement of my complaint, but there was definitely something different in the air, because the Tuesday, Wednesday and then the Thursday before my discharge, everything was fine. And I had one nurse say to me, "We've got to be loving patients. You come in and they're all organised with their medication." Why is that comment different from the Thursday to the Monday? I didn't understand why it changed so drastically. Empathy would go a long way. All you need to do is listen to the patient. The patient knows their body more than anybody else. We know when we need to take our medication. We know when it's wearing off. We know what the consequences are if we don't take it within that 20-30 minute window of when it should have been taken, because my body takes over my control and I don't control it then. If I was
Okay, so that's a very sobering story, and it's just one example of many cases that unfortunately will happen again today across the UK. So now we're going to move on, and there's going to be a case study presented by Fionnuala Johnson, who's a consultant geriatrician and Parkinson specialist, who's going to share with us how the team at South Tyneside and Sunderland NHS Hospital Foundation Trust have approached benchmarking against the 10 recommendations for hospitals and the results. Thank you very much, Fionnuala.
Thanks so much for having me. I'm so pleased, as I said, to be here. So I've already had a very good introduction there, so we'll move swiftly on. What I will be going to do today is I'll introduce our service. I'll be talking about the benchmarking, as Johnny has mentioned, but I'm going to go back a little bit to show you what the baseline has been over the last while and our journey in this service improvement project. I won't be outlining why time critical medications are important, as there are others here who are better qualified to go over that with you, and I feel that this is a group who is probably on board with that message. So we are a large DGH over 1,000 beds in the northeast of England, in an area with multiple indices of deprivation, but quite a vibrant culture around us. We were two trusts, South Tyneside and Sunderland, and South Tyneside, sorry, General Hospital and Sunderland, and we merged in 2019. We use fully electronic prescribing and fully electronic notes, and that's relevant to this as well. Quite a large team, so fortunate to have both care of the elderly and neurology consultants across both sites. We also have an advanced clinical pharmacy practitioner, a specialist physiotherapist, dendron nurse, and most importantly, some might say, 3 excellent Parkinson's disease nurse specialists who are amazing support for our patients. So our story starts really back in 2014 when we had a local sequence looking at whether or not Parkinson's medications were being delivered on time. And because of the fact that we had e-prescribing at that time, we were able to develop a database which it shows each dose of Parkinson's medication that's delivered in the trust and whether or not it's been given within the 30-minute window of its prescription time. That information was really used to demonstrate that we were struggling a little bit and that we could use some additional support from the Parkinson's disease nurse specialists. We also have the capacity to see how many people with Parkinson's disease are in the trust as a result of this database. And this is what it looks like. Okay, so it was clear as part of that we were not performing well, and that's, I think, a fairly common experience, certainly at that time. We've already heard today that 42% of people, only 42% of people are saying that they get every single dose of medication on time when they come into hospital. And I would say that our original data pretty much supported that. So this was an audit done by my colleague, Dr. Huda Gopi, who was one of our training grade doctors, SHOs at the time. And what she found, that this was on a specialist care of the elderly Parkinson's ward, so not, a ward where there was all comers. And even there at that time, we weren't managing 70% of doses of medication given on time. So she started on a campaign of education, spoke to the nurses at the time. You might remember there were the yellow stickers. They didn't go on notes because ours are electronic, but they went on our computers, posters on the walls, conversations with the ward staff. And that resulted in a really very significant improvement in the get it on time rate to more than 90%. But over time that tailed off. And so very sensibly, she repeated the process. And then after she left, that process was repeated and repeated until eventually we had culture change. And we had a sustained more than 80% performance on the Parkinson's ward over really several years. We continued to audit regularly, continued to perform very well. And the trust target was that 80% of Parkinson's disease medication should be on time. So at the start of 2023, my colleague, Dr. Jinyi Tun, who is a prescribing pharmacist, we talked about this and thought the Parkinson's ward is performing very well. But, since we started this work, we now have 2 Parkinson's specialist wards, and there are other areas of high traffic within the trust. Is there anywhere that needs a bit more support? So we looked, and the high traffic areas were the emergency admissions unit, the Parkinson's ward, medical ward had fewer patients, but was a nice comparison and did have several. Orthogeriatrics had a lot of patients due to, unfortunately, higher risk of hip fracture in people with Parkinson's than the general population, and standard COTI ward as well, care of the elderly ward, were audited. And what we found was that the orthogeriatrics and the other COTI ward were really not performing very well, and we wanted to see what the barriers to that might be. So Shinyi had a chat to the staff informally across both of those areas, and the issues across both wards were different. So in orthogeriatrics, there was a real will to want to do this well, but they were struggling to find the medication. It wasn't recognised as a high traffic ward. They didn't know where to get it. So that was actually a relatively easy fix. The very commonly prescribed medications now are ward stock on that ward, and they've been signposted to our COTI specialist ward to be able to access the more the less common medication. On the Coty ward, it was a completely different challenge. They had a very high turnover of staff, lots of very new nurses who were really just struggling to know that it was important, to know how to do the medications outside of the drug round. And so the change that was made on that ward was to include it in the board round every morning to identify people who have Parkinson's disease and when their medications were due. And also the ward manager, who's quite a formidable character, set very clear expectations for her young staff, and that was that. But supporting that, Sydney provided teaching to the nursing staff on both sites about why it's important. And off the back of that, we showed a very significant improvement in performance in the orthogeriatrics ward and the Coty ward on re-audit. We didn't do anything into the admissions unit. I don't know why this was a bad month for them. Generally, they do better than this. And standards were more or less maintained across the Coty ward and the medical ward. And then it was around this time, very shortly after this actually, that the Get It On Time pledge with the 10 recommendations dropped into my chief executive's email, and then my clinical director's email, and then eventually my email. And what we thought was, this is a lever. This is a way that we can embed good practice across the whole trust, so that people, wherever they present with Parkinson's disease, can be confident that they're going to have a good experience. That's really what we're aiming for. So we started the process with a red, amber, green analysis of the gaps between what was recommended and what we were providing. And we really took a granular approach, breaking it down recommendation by recommendation. So I'll share that with you now. So the first recommendation is that time-critical medications should be recognised as a risk for patient safety and included on a patient safety risk register. And at that time, time-critical medications were not recognised on any of our risk registers. Critical medications were when doses are missed, but not late medications. And so we took the video, Time Matters, It's Critical, to our clinical governance steering group, along with a presentation of this gap analysis, and really convinced them that that was an important thing. And the video is so powerful. If you haven't seen it, I would strongly encourage you to, because of course it's been put together by colleagues, some of whom are with us today, and really I think helps to make it relevant, personal, and applicable to an NHS setting. So they were really won over by that. And then the next one is hospital staff within hospitals should be made aware of time-critical medication. We've already shown that there was an issue. People didn't necessarily know when medications were due. And so we discussed at the clinical governance steering group, which I should say is a meeting where we have our clinical director, the head of nursing, clinical governance lead for the trust, and various other great and good. So high, high ups who can make decisions. And there was some discussion around the fact that 4 minutes across several thousand staff was quite a lot of lost productivity, and there was a bit of back and forth on that. But eventually what we settled on was that it should be part of the induction for all prescribers and all people who are administering medication. And so that's now the situation. So we are green on that now too. We should identify which staff should undertake further Parkinson's training. We were amber on that side. We had quite robust teaching for foundation doctors and medical trainees, and also pharmacists, but really not very much that was formal for nurses. We had an e-prescribing module, but because of the turnover of staff, compliance with that wasn't great. And we had no mechanism to identify people who were struggling when it wasn't on the specialist wards. And so what our plan was for that was to spread our audit out throughout the whole of the trust, to use that as a way of identifying areas of underperformance. As you know, we've said mandatory training for all prescribers and administrators, even though it's only brief. It's a touchstone, isn't it? And then an expectation was set that on the Coty specialist wards, that the e-learning module that our Parkinson's nurses had previously produced would be completed. We also had enhanced training in person, face-to-face, by physiotherapist, and my colleague, Dr. Caulfield, who is one of our other Parkinson's specialists. And the plan when she comes back from maternity leave is for that to be expanded to orthogeriatrics as well. We should update a have and maintain a self-administration policy for patients who can administer their own medication. I'm very much looking forward to learning more about how other trusts have handled this. We had a self-administration policy for insulin that was being developed and a plan to jump on the back of that. We have done that. We've got all of the documents in place. We've got everybody on board. It's been approved by everybody, but we are stuck with not being able to get cabinets that are suitable to be opened by people with mobility issues, dexterity issues, and are also infection control compliant. So I look forward to that. That's our only remaining amber, but important, as you've already heard. We were green on ensuring that patients are identified with time-critical medication in the emergency department. Many of you may have seen this RChem poster. It's not specific to Parkinson's disease, but encouraging people to contact our staff if they have time-critical medication. And people are asked at the time of triage whether they are on any time-critical medication. Moving into the admissions unit within medicine, all of our patients who come to the EAU have medications reconciliation by pharmacists who will identify whether or not there are any time-critical medications and ensure that they're prescribed. And at their home time, anybody who is on our list, because that's all electronic, who's coming into the EAU overnight, will be identified and a plan made as well. Okay. Do we have a standard operating procedure for time-critical medications? Well, we said amber at that time because we had a critical medications SOP, but not one for time-critical medications. And so this was discussed at our medicine safety group, who agreed that this was important. And now we have a time-critical list, again, not Parkinson specific, also includes insulin and anti-epileptic drugs, but is really much higher on the agenda in terms of our patient safety teams here in the hospital now. All of our areas have a designated pharmacist responsible for ordering and stocking time-critical medications, so that was green at the outset. Time-critical medications should reflect the normal daily schedule for people that they follow at home. This was clearly outlined in our inpatient management of Parkinson's disease guideline, with support on e-prescribing on how to actually do this outside of the drug rounds as well. So we rated ourselves as green on that side. We should have a standard operating procedure for people who are nil by mouth, and this is also included in our guidance, in our guideline. This is just for your interest, the flowchart that we use for that. And I'm pleased to report that last time we audited this, which is after this work, that over the months, all of the people who are nil by mouth, nobody missed any doses of medication. So I was very happy about that. I don't know if it'd be as good next time, but I hope so. And finally, ensure that staff have a system so that medication can be delivered outside of usual drug rounds. Now, we had the system, we had the means to do that, and this is what the page in the guideline I was referring to looks like in terms of a step-by-step guide of how to physically prescribe it, but it wasn't really being done. It's just, sorry, I can see someone saying they can't see any shared documents. It's this one here. So although we had the system, I felt that this was amber because we weren't doing it. So that was part of the conversation, was trying to upskill everybody to make sure that's done. So this was the trust-wide audit that we did off the back of this. The blue bars are the number of doses that are given. Just for interest, this is the Coty Specialist Parkinson's ward, the first one. This is the second Coty Specialist Parkinson's ward. You can see well into the 90s there. This is orthogeriatrics, had dipped a bit since our last audit, so kind of 75, and then going down through areas where they have some traffic of people with Parkinson's disease who are on medication, but perhaps they're not getting them in as often as they should. Trust-wide, though, we had 83.4% of doses given on time, which if you cast your mind back to our 2015 data is quite nice. But we want to smooth that curve. We don't want anybody having a bad experience wherever they attend. So we identified places that were outliers. So do they have a lot of traffic, but they're dipping below that 80%? Or are they just really, really struggling with this? So 5 wards were identified as outliers, and were contacted. This is work, sorry, I should have said, done by my colleague Jade Young, who has really been passionate and excellent in driving this forward. I've been very grateful to her. She carried out a survey on the wards that were struggling and identified perceived barriers to why the medication wasn't given on time. And what was really interesting about that was there was a bit of a mismatch between the confidence of having the knowledge and use of the resources we already had. And actual, knowledge of how it's important. So patient factors were listed as a high reason for people not getting their medication on time. But you've seen we have clear protocols where patients who are refusing medication need to have a capacity assessment and escalation to a doctor for an alternative route, and clear guidance for what to do if people aren't able to swallow as well. Clinical pressures are clinical pressures and will always be challenging, and it's finding a way around that, really. Medication unavailable on the ward. So our advanced pharmacy practitioner, I already mentioned, has done some training with the pharmacy technicians as well as with our pharmacists, so that they understand exactly where medications can be accessed. And then out of hours, within our guidance, there is also how to obtain these medications as well. Timings are easily forgotten. That's not an easy solution, and actually ward by ward the solutions to that have changed, are different, but having this conversation seems to help. They weren't aware that it's a time-critical medication. Well, I thank them for their honesty on that. That's useful to know. And again, end of life, we have clear guidance on what to do if people aren't able to swallow at the end of life, and someone reaching the end of life is not a reason to not provide them the care that they need and consider the Parkinson's disease as part of their holistic needs. So after all of those interventions, this is what it looks like in our most recent audit. Every ward improved, and I think that's a reflection of the conversation being had frequently. If you remember back to the data that we had from 2015, we know that things tail off. So the more we can talk about it, the better things will be, and the more the culture will be embedded. Every ward improved. This was our ward, 98% on time, which again shows how important it is to bang the drum. But more importantly, no one is now less than 50%. 50% is clearly not ideal. However, no one is getting none of their medications on time, which is where we were. And these are different wards. So all of these wards who were targeted performed really very well. And because we've ranked it on the number of doses compared to the percentage given on time, it's difficult to illustrate that. But these are actually different areas. So the hope is that over time, as we continue to re-audit, everyone who struggles will get a reminder. And we're planning to do this yearly. So what have we learned? We have only been able to do this because we have electronic prescribing and because we have good data. That is absolutely key, to know where you are. I would not have been able to achieve any kind of culture change if our senior leaders were not engaged. And the video from Parkinson's UK is extremely helpful on this, but nothing changes without engagement with senior management. Culture change takes time. This has been a 10-year process and will never be finished, because we are going to have to continue to have these conversations over and over again. I've put the canary here because I feel that this is a canary in the coal mine issue. It's really hard to give medication on time. It requires attention to detail, it requires patient-centered care, and it requires compassion. And if you can do all of those things, then the chances are that you're providing pretty good care in every other sphere of your ward. So where things are sliding, conversely, it's somewhere to see, is everything okay? So I hope that you agree that this has been really valuable, not just for Parkinson's, but also for patient-centered care in general. And thank you so much for having me and letting us share our work. Any questions? I'll stop sharing. It's all gone very quiet. I can't hear anyone else or see any questions.
Thanks very much, Fiona. We'll see if any questions come in. We're going to be moving on to a time of questions now, so potentially those could come into the next session as people think about that fantastic presentation. I mean, my question would be, there's no answer, but it would be great if we could clone you and take your work and put it across the UK. It'd be absolutely fantastic. The work that you've done is absolutely amazing, and it just shows people what is possible with support from senior managers. And whenever we were writing the document and making the video, it's just great to see it actually in action, which is what we anticipated or what we hoped for. So it's absolutely great. So any questions around that for Fino's presentation? If you just put it in the chat. If you go on the next slide, then Emily. So we're going to have a half an hour now where it's a question and answer session with the panel, and if you just put your questions in the chat. We have received some questions in advance, so we'll go through those first. As we answer those, and it might spark another question that you might want to ask, so just put that in the chat as well. We'll aim to answer as many as we can during the time we have, but if we've received so many that we can't cover them all today, we'll capture all of the questions that have been put on the chat that haven't been able to answer, and we will respond, the panel will respond after the event with the document. So the panel will put their cameras on now and make sure they're unmuted, and we will go for the first question, which is to Nick. So Nick, somebody has typed in before the event, what are the critical signs and symptoms of a patient who may not have well managed Parkinson's?
So firstly, thank you for the question, and the nice simple question to begin with, because I think there's so many different signs. But with Johnny's work in ED, I think a lot of people when they first present may not have had their medications for several hours or several days. And I actually did a quick Google search, as we recommend that people don't. But I did a quick Google search as to what people find, and actually the top one was what I would have said as well. So it's Parkinson's hyperpyrexia syndrome is the biggest risk if people do not get their medications on time. And it's often mislabeled as infection, reduction in function because of something else. And it can present like any other condition, increased rigidity, high temperature, reduced conscious levels. So people can straight away think of infections, can think of other reasons, stroke, anything like that. We should be checking a creatinine kinase on patients who hit ED that have a reduced conscious level that are particularly stiff. That can be elevated hugely because of that, but it can then cause, in 4% of cases, people die because of that particular condition, and it's often mislabeled. So we should find out from people when they last had their medication. But that's the critical thing that can happen, but it can also happen in a ward. So if someone has missed a dose or has missed a couple of doses, it can take as little as that to cause the syndrome. And people will deteriorate quickly. They will end up in ITU. But I'll also flip the question in the other way. What can be improved if people get their medications on time? Is probably the way that I try and sell it to staff now. And we produced a slide which is not exhaustive. So less pain, able to move, better speech, less dependent on the nursing staff and the doctors. So we're having to sell it to people now, and that their workload is less. Mrs. Smith can get up and walk to the toilet with assistance of one rather than two. But the medication should be at the time of the person at home, and that doesn't work well with normal ward rounds. Normal drug rounds. But we should be looking for those critical changes. But also increased anxiety levels can be a simple one as well. But we can have less hallucinations if meds are on time. Difficulty controlling their emotions. So they are much more agitated. They're out of their own environment. So we should not be making them worse by not giving their meds on time. But simply look at the amount of time it takes to deal with that patient. And if that is rising, then look at whether you're giving the medications on time. I hope that gives at least an answer, and we can talk about it more later.
Lovely, Nick. That's absolutely great. Thank you. Fiona, we've got a question for you. There's a couple have come in, so I'll just mix them up. So the first one is, what was the biggest barrier to your work when this all started?
I would say baseline knowledge. Actually, people just simply didn't know that the positive impact that giving medication on time could have and the negative impact that not having it could have. And I think hearing patient voices in that has been the thing that has made the difference in terms of bringing people on board. There is also undoubtedly, there are clinical pressures, you know, and nursing staff already sometimes feel quite overwhelmed with all of the work that they're being asked to do. So conveying the fact that this is actually something that will help them and make things easier is helpful as well. Everybody comes to work to do a good job. Everybody wants to do a good job for their patient, but sometimes the pressures of work make it challenging to do so. So it's trying our best to give people the tools that they can and make it as easy as possible to do a good job.
Lovely, thank you. So we'll come back to you again shortly. One of the other prepared questions that came in was for me. It says, any ideas on how to make sure time-critical medication are administered in a busy ED department? We have specific visual, different coloured care request forms currently. So this is the $1 million question that I've been trying to answer for the past 3 years. I think the key to this, I think, is early identification. So if you can identify early that the patient is on a time-critical medication, then you have more chance of them getting their medications on time. And I think EDs that are paper-based, it's more challenging than EDs that have got electronic systems. Obviously, paper departments can still use the yellow get it on time stickers. There is a Pacific ED any yellow get it on time sticker. The Parkinson's UK have produced this on their website that asks 3 questions. It says, have you your medications with you? When's your next dose? And are you willing to self-administer? So that's the first thing. People don't present with Parkinson's. They present as a result of Parkinson's, so falls, infection, heart failure, comorbidities, psychiatric complications, etc. But they don't walk up to the triage desk or in the ambulance to say, I have Parkinson's. So they're sort of under the radar, and we have to be a bit Poirot-like to discover them. The second thing that might help is the RChem. We've written a position statement on self-administration within the emergency department, which is going to be published in April this year. And it basically, the self-administration policies within the trust within the wards doesn't fit with the ED because we just don't have time to do that, and we can't have every patient having a cabinet because it doesn't work. So we won't have the same infection control issues as Fionnuala has. But it will basically have 4 principles that individual trust will have to hang the detail on. So the first one is, does the patient show their medication? So if somebody arrives in and is able to take their medication out of their pocket or out of their bag and show it to the staff, that sort of tells them that they know they're on a time-critical medication and that they want to take it themselves. Now, then will be an assessment. What that is will depend on each ED. The patient will either be then allowed to take their own medication or they'll be aided to take their medication when the staff will help. And finally, there was a lot of debate about monitoring. So we came to the conclusion that if a patient wants to self-administer, they can do that, but the nurse needs to come in and watch the patient do it and then documents it on the system, either on the paper drug codex or the electronic chart. And the reason for that was that, from a governance point of view, but it actually empowers the patient. So they could be sitting in cubicle 18 in majors with 50 other people. They know they're due their meds in 5 minutes. They ring the buzzer. The nurse comes in. They say, I want to take my meds. And then the nurse watches them take them. Now, the QIP showed that 10% of people last year in our QIP, people with Parkinson's, self-administered. We had a rate of about 20%. So it is possible to do. So we'll be interested to see how trusts take that document and implement it. Again, e-prescribing is really important. Patient departments that have e-prescribing are, I think, more likely to be able to identify and deliver medications on time if they have that. And we've always wondered whether there was a gap between ED and going to the ward. So traditionally in emergency medicine, we would prescribe emergency drugs, so fluids, antibiotics, any emergency, salbutamol, thrombolysis, anything that needed an emergency drug, adrenaline, etc. But now that with patients waiting, the patients aren't getting their medications when they need them, and certainly time critical medications. And we have focused on two. So we focus on Parkinson's and insulin because really they are the two. There are lots of time critical medications, but the two that really matter, which have a time frame within 30 minutes, are Parkinson's meds and insulin. So that's how we've done it with the college, but we've encouraged staff to not just prescribe their first dose, but all their doses at the time they see them, even if they don't know whether they're going to be admitted or not, because what we found is 80% of people with Parkinson's in the QIP arrived by ambulance and 80% were admitted. So the majority are coming into hospital. So that's why we say, prescribe them all. We thought a lot of patients might need an NG tube or a patch. There was actually very few did. The very few needed a patch or an NG tube to get their meds. Most of them could take them orally, which was quite surprising. And then I think if you identify and you prescribe, then, there's the responsibility of the inpatient team to take that over. But if the patient's still in the ED, it's still the ED nurse that has to give them. So this debate about, it's not my patient, we've handed over. The ED nurse still has to give it because they're still in the ED. So it makes sense that they're prescribed. So we'll talk a bit more about identification in the workshop this afternoon. So Phil, can I come back to you and just ask who carries out your capacity assessments and how often do they need to be reviewed?
Okay, so this is obviously very specific to the question around does this patient have capacity to refuse this medicine at this point? Capacity being time and decision specific. But our critical medications SOP says that if a patient refuses a critical medication, then that triggers a capacity assessment by a doctor. It could be any doctor that's qualified. It happens even on call, and a plan has to be put in place. It isn't that time consuming. These patients need to be reviewed anyway, I would argue, because either they've become delirious or something has changed and they're about to self-discharge. And if the patient has capacity and doesn't want to take their medication, bearing in mind this is not specific to Parkinson's disease, then of course they have capacity to do that. People are allowed to make unwise decisions. However, if they are have become delirious and not able to make decisions around their care at that point, or perhaps are agitated, then an alternative plan needs to be put in place. And that alternative plan might be let them calm down, bring their relative in, we'll ask them again in 20 minutes. There are some least worst options in that scenario, but it's very patient specific. I hope that answers your question.
Yep, no, that's great. Thank you very much. So moving on to the next one. So this question is for Jean. Management of patients presenting to hospital on an apomorphine pump. Any information for healthcare professionals on the newer Dupa gel pumps?
Yeah, Johnny, we did some research because this was a question that we received in advance of the webinar today. And what we found was that there are educational videos such as pump training videos, and patient materials which can be downloaded from the newly launched APCO Go website. I'll put that in the chat. There are some user instructions and setup videos for the pumps and the pen, as well as downloadable guides for the two pumps, which are available from that website on the education resources page. And there's also a phone number for the technical helpline, which I will share in the chat in a moment. So we actually contacted the manufacturer of the pump, and they were unable to share that information with Parkinson's UK because we are classed as members of the public, not health professionals, which I'm sure people on the call can understand. But AbbeyV can provide resources direct to healthcare professionals. So the people who are on the call today should be able to access that information. And I will pop that because there are some phone numbers and some links in the chat, Johnny, so that everyone's got access to that information.
Lovely, that's great, Jean. Thanks very much. So just going to move on to Emma now. Emma, the question that came in for you was, how would you deal with managing medication in MDS trays to keep PD patients independent when taking 5 times a day and over?
So for this, I'm going to take this question as it was intended, that how do you deal with the MDS trays when you're in an acute hospital? And I think this is difficult because the nurses don't always know what's in them. And so there's a reticence to use them because you don't know. Lots of them now have labels explaining, round blue tablet is this drug, yellow and green capsule is this drug. So that's really useful. I don't think we need this to be a barrier. If you don't have the supply of the Parkinson's medicines on the ward, then it is sensible to use it from the MDS tray. Often we wrap ourselves up in what the policy says, we're not allowed to use it. What we need to be here is pragmatic. We need to get the medicine for the patient. We don't want to give the wrong medicine, so we need to know which medicine it is. Some medicines in that little box, that particular slot, may have been stopped, so we need to go a certain way to assure ourselves we're giving the right medicine. I would suggest contacting your pharmacy department. We have systems where we can work out what the medicines are, but I think it's about it. Often, like in the video before, computer says no, you can't have your medicines, we're going to take them from you. It's not about that. We need this to be patient-centered decisions. What is the best option at this point for our patients? And it is about being pragmatic and not saying the policy doesn't allow us to do this. We need our policies to be flexible enough that we can bend the rules, because we need to get the medicines to the patient. So if people have trouble with that, I would suggest you need to get in touch with pharmacy, and we need to really think about it from the patient's perspective, not just about not using something and medicines being locked up. There are CQC regulations, medicines need to be locked up. This often is a barrier for self-administration as well. We need to risk assess each of these individual decisions. I'm not talking about doing a risk assessment on paper on the computer, but it's about having that thought process and documenting what your decision is. But we should always be trying to make sure that we get to the medicines to the patient, and in whatever way we can. Great. I hope that answered the question.
Yeah, that's great. Thank you, Emma. So moving on, the next question was for me. What was the average length of stay for a patient who's missed time-critical medication within ED delays? So we know that a missed dose will increase the length of stay. We know that a patient with Parkinson spends on average 4 days in hospital longer than other patients. There are multiple reasons for that, but one of them can be that the patient hasn't got their Parkinson's meds on time, and that's why the ED is so important, because if they're not identified and they miss doses in the ED, they're just not getting home. They're not going to have a successful physio assessment and potentially not get home. And hospitals should be places where people can rehab and not deteriorate. I remember speaking to some patient, a relative once, whose husband came through our department, and she basically said he doesn't get his meds all the time, and every time he's come out of hospital, there's decline. So and that's the unseen. That is the unseen effect of this. There's a difference between an 80-year-old man going into hospital who can climb the stairs, and to going into hospital, an 80-year-old man not being able to climb the stairs. That is a massive impact on him, his life, and a massive impact on his carers as well. So I think we've got all time. I think we've got about 7 minutes left before the break, before the session ends. Finn, I'll come back to you. How does the self-administration policy in your trust work in your own area? And is it specific to your ward, or is it transferable across all wards? I think you might have covered that.
So this is the only outstanding amber. We're not there yet with this. The policy that we've devised is purely for the Parkinson's ward, but there is a separate insulin self-administration policy which is being delivered now on the endocrine ward, and also in our ICAR, which is our intermediate care and rehab hospital. They they are also moving towards self-administration for all medications with a view to improving independence before home. The plan is for it to be trust-wide eventually, and to have a unifying policy, which is why we've tried to link in so closely with those areas, but we haven't been able to start. It's been a several months delay because of the issues around cabinets, as I mentioned.
Okay, that's great. Do you think your trust would agree to sharing your self-administration policy? Would that be, do you think that would be something they would be willing to do?
I think they probably would when it's done. I feel it would be a bit early. We're jumping the gun a bit to share our work at the moment, and there are others here who are more qualified to talk on this topic anyway.
Okay, lovely. Thank you. So let's just see what we've got next. There's loads of questions coming in, so let me just get one. Okay. So Claire, do you think patients have a role in this? With you know, they should have their medications on them. So what can they do to help the process?
Yeah, we've talked a lot about education of staff, but absolutely really important that patients take some ownership of their well-being too. And we're certainly working now, as you know, Johnny, now with Parkinson's UK, to start to think about how we empower patients and educate patients, prepare patients for hospital admissions. Now, often these admissions happen in an emergency situation. They're perhaps less able to advocate for themselves, and that's where their carers, their nearest and dearest, their 24/7 support needs to be also upskilled and informed enough to represent them in an emergency. But when they're coming to hospital in a planned way, there are tools and resources out there, particularly through Parkinson's UK. There's a fantastic booklet for patients going into hospital, which helps them to understand about what they need to take with them, but how to advocate for their medication, how to advocate for their particular and specific patient-centred signs and symptoms so that they can be best supported in hospital. So yes, absolutely, we as a patient group need to do our bit to help our healthcare professionals support us in these situations.
Great, I think that's really important. And I think that's one of the recommendations we made from the RChem, time critical medication QUIP, and that's basically to encourage charities, primary and secondary care, to encourage patients to use the term time critical medication when they arrive into an emergency department. I am on time critical medication. Staff, hopefully with the work that's been done here and the continued work nationally, that once patients say that, something will happen that will hopefully ensure that the process starts from the minute they access the NHS. Somebody's asked, Johnny, how do you take your meds on time in the ED? You're very busy? Do staff remind you that you need your meds? So that's quite a good one. So I have my meds. Where are they? I thought I lost them. Got them with me here. Claire's rehearsed. I used to have them in this little screw-on thing, but what happened about a month ago is that my 3 Stalevo doses got stuck, like jammed in, and I couldn't get them out. So I had to phone my wife and say, I can't get my meds out of the thing. So she came and gave them to me. So I have reverted back to the bottle, which shakes. So that sort of is a reminder all the time that I need to take them. But personally, I know, because I can feel it. I feel it down my left side, and I cognitively zone out. So I will zone out. And non-motor symptoms are something that's missed in all of this. The anxiety, the fatigue. My wife used to describe me as being on a different planet. Now, if you're in cubicle 3 in ward 16 in a general hospital, you can't convey that to staff. You can't see it, because they might feel stiff. If they don't have a tremor, you don't see it. They may be sleepy, but they're not sleeping. They're sleeping because they haven't got their meds, and they're fatigued, and they just got their voices weaken, and people just walk past them. So we really need to do better. But for me, I set an alarm on my phone, and it goes off, which is a backup. So finally, let's see, we've got about 2 minutes left. Final question. So for the final question, you mentioned engagement of senior leaders as being really important. In fact, it was key. What persuaded them to take action on this issue? And through your work, did you also see knock-on improvements for other time-critical medications, such as insulin or epilepsy?
So I think it really helped being able to put the video to them where it was very relatable to them. That absolutely was really helpful. But also being able to show that we could do well, and now it's become a source of pride within the hospital, and that's very motivating for my senior colleagues. I've just been back to present this work again at the Clinical Governance Steering Group to show them the update from last year from the original Red Amber Green, and the conversation from then was, how can we extend this to insulin, how can we extend it to anti-epileptics, because our database is very specifically around Parkinson's medications because of the sequin at the outset. I don't have access to that information, but I know that that conversation is happening, and I expect to see it probably pretty soon.
Okay, that's lovely. And finally, just moving on from that, were you able to show that there was a saving? You know, did patients spend less time in hospital? Were they discharged quicker? Were you able to make the link between that?
No, we haven't done that work, and it's important. But I think for me, our first step is to make sure that people don't have a miserable experience, because I have several patients who have said to me that they never ever want to go back in hospital again. And so even if there is no change whatsoever on length of stay, I still think that this work has inherent value.
Yeah, brilliant. That's great. Thank you. So there's a couple. So just to summarize before we head off for a 15-minute break, if you can come back for session 2, please do. We'll continue the discussion. I mean, for me, it's really around, you know, we've seen how the 10 recommendations document can be implemented in a hospital, and the results that that's shown. Identification, early identification is so key, and we all have a role to play in that. And the other thing that I did mention is, if you want the chief executive to read one thing after this, there's an HSSIB report of an 80-year-old man who walked into an emergency department who'd had Parkinson's for a few years. He was on, I think, a reasonably high dose of medication 5 or 6 times a day. He self-administered his first 2 doses because he had them with him. They were taken off him. He then got, I think, 9 out of 18 further doses. By the time he reached the ward, he aspirated, and unfortunately died every 4 weeks later. And that's just such a sad story, because that just didn't need to happen. It was preventable, it was avoidable. And by implementing those things that we've talked about this morning, then it'll protect patients in the future. So thanks very much for coming to the first session. Have a coffee, stretch your legs, and we'll see you back at 10:55.